Hello, this is Kim Jong-il. Today we will look at retrusive control in clinical orthodontics. What does retrusion mean? When the mandible or condyle is located posteriorly, it is called retrusion. So what does retrusive control mean? Controlling the posterior movement of the mandible and condyle is called retrusive control. Typically, you want to do OE occlusal equilibrium in patients who have occlusal interferences. However, some occlusal interferences may prevent the mandible from moving backwards. This is the retrusive control. An example is a full Class II malocclusion patient. Let's look at the occlusion on the lingual side. When viewed from the lingual side, the lower canine contacts the lingual cusp of the upper premolar so that the mandible no longer goes backwards. If there is no such point of contact, the mandible will constantly try to move backwards, increasing the likelihood of developing TMJ disorders. Also, in the case of Class III, the anterior movement of the mandible may be more than full Class III. Retrusive control is to prevent the mandible from moving backwards due to contact of the premolar area. What will happen if the mandible can't move backwards? The mandible is positioned slightly anteriorly. The mandible can move freely anteriorly and laterally. As the lower premolar cusps contact the lingual cusps of the upper premolar, the mandibular condyle cannot move backward, and it is located slightly anteriorly. If the condyle of the mandible goes back, the likelihood of TMJ disorders increases. As humans walk with two legs, many changes occurred in the skull. What changes have happened? First, the skull of mammals such as dogs and cats has a bony barrier. In other words, there is a bony process behind the condyle so that the mandible cannot go back. On the other hand, humans do not have such a bony barrier, which increases the likelihood that the condyle will move backwards. Second, humans' upper and lower canines are less pointed than other mammals. Chimpanzees and gorillas have sharp canines in the upper and lower and touch each other to prevent the mandible from moving backwards. It can be seen that there is a primate space in the anterior of the upper canine and in the posterior of the lower canine. On the other hand, humans don't have such a space. Also, in humans, the arch itself is in a closed arch state rather than protruding forward. In other words, humans have a closed arch concept unlike other mammals, and since there is no bony barrier and the retrusive control is weak, the condyle of the mandible tends to go backwards. What if the cranio-mandibular system is disharmony with the occlusion during orthodontic or general dental treatment? This disharmony is caused by the orthodontic force or dental treatment that moves the condyle backwards. If the condyle move backward, the likelihood of developing TMJ disorders increases, and muscle or ligament pull the condyle anteriorly to compensate for the posterior movement of the condyle. Therefore, the patient's muscles and ligaments may be overloaded. Also, if both condyles are located posteriorly, it may result in Class II malocclusion. On the other hand, if one side is Class I and the other side is Class II, the possibility of midline deviation increases. Therefore, in the case of patients with TMJ disorders, Class II malocclusion, and midline deviation, you should observe the patient's condition more carefully. When orthodontic treatment is performed, it is called retrusive control to make cranio-mandibular system in harmonious condition. When will human first get retrusive control? It can be obtained when the upper and lower first molars erupt. The upper first molar has a distinct oblique ridge, and the distibuccal cusp of lower first molar is located in the central fossa of the upper first molar. This is called a retrusive barrier. In other words, the distibuccal cusp of the lower first molar touches the oblique ridge of the upper first molar, thereby inhibiting the posterior movement of the mandible. When waxing up in clinical practice, you can wax up one layer as shown in Figure B, or two layers as shown in Figure A. At this time, if only one layer is waxed up, there is a high possibility that the barrier collapse and the distibuccal cusp of the lower first molar will move backward. On the other hand, if two layers are waxed up, even if the barrier collapses in the first layer, the second layer will be able to prevent it. It is very important to make a class 1 molar relationship after the first molar erupts. If the vertical height is formed through the class 1 molar relationship, the mandible will adapt to it. Then, a retrusive barrier is formed. Let's look at this patient. The upper first molar has been treated with gold crown, and there is almost no oblique ridge due to wear. In this patient, the first molars of the upper and lower generally erupt around the age of 6. As I will lecture again later, the most important tooth in retrusive control is the first premolar of the upper and the lower. The first premolar of upper and lower erupts at the age of 10. In other words, the relationship of first molars is important for 4 years. If the first molar relationship collapses during this period, the mandible will continue to move backward, increasing the likelihood of a class 2 malocclusion. The profile of this patient is not very bad, but the mandible is located posteriorly. The molar relationship is full class 2. The first premolar is erupting, but if the full class 2 relationship does not improve until the first premolar has completely erupted, the class 2 relationship will worsen. After the upper first molars erupt, it is very important to evaluate the position of the upper first molars on both sides. In other words, we should observe whether the upper first molar is in mesial rotation or is parallel. The buccal side of the upper first molar should be parallel. If some tooth is lost prematurely, there is a high possibility of mesial rotation of the first molar. Also, the line connecting the upper distibuccal cusp and mesiolingual cusp should pass through the contralateral canine. However, if the upper first molar is mesially rotated, this connecting line is located posteriorly, not the canine. Therefore, observation of the mesial rotation of the first molar is absolutely necessary. Many orthodontists said that as the upper first molar mesially rotated, the maxilla has a V-shaped arch form, and in this case, lateral movement and anterior movement are limited. If you derotate the upper first molar that has been mesially rotated at this time, the class 2 relationship will also be improved, and the mandible can be moved to its original position. When the teeth are rotated mesially in this way, the mandible is located in the oblique ridge compared to the teeth rotated in parallel. If this oblique ridge collapses, there is a greater likelihood that the mandible will be located posteriorly. In the case of mesial rotation, there is a high possibility that the retrusive barrier will be lost. As a result, the mandible is located posteriorly and the maxilla is located anteriorly, resulting in class 2 malocclusion. The most important thing is the relationship of the first molars. As the first premolar erupts, stabilizing the mandible position. Then, retrusive guidance and forward guidance are formed. Let's look at the occlusal relationship in normal growth. When a tooth erupts around the age of 6, 7, or 8, it can be seen as a class 2 relationship. Then, it can be seen that the lateral tooth group occluded and the class 1 relationship was well maintained. In class 2 development, it shows similar patterns at the beginning of occlusal development. At first, it was class 2, then changed to class 1. As the lateral tooth group occluded, looking at the left side of this patient, you can see that it changed to full class 2. What's the difference with a class 1 relationship? You should evaluate whether the cusp tip of the lower first premolar is located distal or mesial of the upper first premolar. At this time, the cusp tip of the lower should be located at the mesial of the upper first premolar. The cusp tip of the mandibular first premolar should be located at the mesial of the maxillary first premolar at the time the lateral teeth are exchanged. If not, it results full class 2 relationship. Therefore, if you take care carefully at the time of lateral tooth group exchange, orthodontic treatment will be much easier. The upper first premolar erupts. Should the upper first premolar be located at A when it erupts? Should it be located at B? The lower first premolar should be in the B direction, and the upper first premolar should be in the A direction. At this time, the shape of the lingual cusp of the upper first premolar is important. The shape shown in the photo prevents the lower from moving backward. That is, the mandible cannot move backward as lower first premolar touches the inner slope of the lingual cusp of the upper first premolar. The lingual cusp of the upper first premolar should be located in the distal fossa of the lower premolar. Creating this position is an important factor in orthodontics. Let's look at the morphology of the upper first premolar. A slightly concave side can be seen in the first premolar. Which side will be the mesial side? Is it A? Is it B? One side of the concave is the mesial side, like in B. Why is one side of the concave the mesial side? This can be thought of as an evolved root form of the upper first premolar to prevent the mandible from moving backward. Therefore, you should carefully look at the shape of the lingual cusp of the upper first premolar. The shape of the lingual cusps may be sharp and large, but in some cases the lingual cusps are barely worn. At this point, the mandible is most likely to be located posteriorly. Looking at the meaning of the retrusive control, it can be seen that the curve connecting the left and right sides of the condyle has almost the same shape as the curve connecting the oblique ridge retrusive barrier of the maxilla and the first premolar of the maxilla. In other words, first premolar and upper first molar have these shapes to protect the condyle or to prevent the condyle from moving backwards. Explain again. The lingual cusp of the upper premolar is located in the distal fossa in the lower first premolar so that the mandible cannot move backward. It is not easy to see the lingual side, so you need to look carefully at the buccal side. You should keep in mind that on the buccal side, the cusp tip of the lower premolar is located at the mesial marginal ridge of the upper premolar. During orthodontic treatment, it is important to carefully observe that the cusp tip of the lower first premolar should be positioned at the mesial marginal ridge of the cusp of the upper first premolar. How should the teeth move in the picture? The upper teeth will have to move posteriorly, and the lower teeth will have to move forward. I will explain in more detail in part 2. Thank you for watching.